Hello everyone, my name is Will.
And my name is Ellie.
Welcome to Lively Minds, the podcast about mental health challenges that go beyond the ebb and flow of the everyday.
The podcast that looks at how building a better understanding of our mental health can influence how we address it.
Today we are talking about the complex and timely issue of overdiagnosis in mental health. We are joined by two guests today. Dr Elspeth Dav is a medical anthropologist at the University of Oxford, whose research focuses on the social and ethical issues surrounding diagnostic categories.
And Dr Helen Salisbury is a GP and a columnist for the BMJ. Together they bring a brilliant combination of an anthropological lens and a frontline clinical perspective to this conversation.
Elspeth and Helen recently co-authored an article for the BMJ titled "How Do We Talk About Overdiagnosis of Mental Health Conditions Without Dismissing People's Suffering?" In it, they explore the growing tendency to medicalise distress and unpack the delicate balance between a diagnosis that helps and a label that harms.
In this episode, we're going to discuss how we define overdiagnosis and how, as a society, we strike that balance between validating a person's experiences while avoiding the reflexive use of clinical labels.
Welcome, Elspeth and Helen. It's great to meet you.
Thank you for having us.
Great to be here.
So to start with, I just wondered for our listeners if you could define overdiagnosis in the way that you see it.
This is a contentious question. There's been tens and tens and tens of papers written about this. But very broadly, we can think of overdiagnosis as a diagnosis that doesn't benefit the person in question, so the person who's been transformed into a patient. Yes, that's a very broad definition. I think one of the complexities is that we talk about overdiagnosis happening in symptomatic context, so in the context of mental health, where people feel unwell and then they visit their doctors. And we also talk about it in an asymptomatic context, in a screening context, where we invite people who are healthy to be tested. And these kind of different types of overdiagnosis get conflated, which is where the definition gets a bit thorny. But very broadly, it's an unnecessary diagnosis where the person won't benefit from it.
And I guess following on from that, why, in the context of mental health, why do you think it happens?
I think there's a really interesting question about how much of how many of the labels that get applied in general practice are medicalisation of what some people would think of as normal. So people come with distress and low mood and anxiety, and those might be actually relatively normal reactions to what is going on in their lives. When you see someone a few months after they've been bereaved, it's kind of not surprising that they're feeling very low. Should they have a label of depression, for example? And that is something you can talk about at great length, and how much having a label is useful. But medicine, the tendency is to make a diagnosis. When people come to see a doctor, that's the thing that the doctor is quite likely to do, is make a diagnosis. And I think there's a really interesting thing that maybe doctors aren't taught to do enough, which is, I can see that there are things going wrong and you have symptoms, but I don't have a label to give you or a diagnosis to give you. And how we actually navigate that territory, how we manage to really say to patients, I hear you and I hear your suffering and I absolutely believe where you are, but I don't have a label to give you. That's quite a difficult place to be at. And therefore, I think a lot of people who do come with symptoms go away with a diagnosis of anxiety, of depression, or another mood disorder, another mental health disorder. And the question is that helpful for the patient? Is what follows on from a diagnosis a form of treatment? And is that treatment the right thing? And what does that labelling do for the patient's thoughts about themselves? And that's really where Elspeth's expertise comes in, I think.
And just to add to that, it's not just that diagnoses validate patient suffering. We also have a system that is fundamentally built around diagnoses. So you need a diagnosis if you want to access certain benefits or adjustments at work or certain kinds of medical care, perhaps. So there's strong incentives to offer labels and diagnoses when patients report these issues.
Can we actually just dig into how a diagnosis works? Because what counts as a diagnosis? I guess you could go to a GP and the GP could say, well, based on your symptoms, this is what I think might be happening. Obviously, there's psychiatric assessments, which would be much more thorough and more in depth. So when you're talking about diagnosis, where on the scale are you talking?
I think that's really quite a difficult question. There was a vogue a little while ago for endlessly filling in scales, boxes to tick. How many points did you get on your depression inventory or anxiety scale? And mostly doctors will make a diagnosis on the basis of the whole interview that they have with somebody, which will be both what they say about themselves, but also their manner, their demeanour, how they're coping in the world because of their mental condition. And I think it's difficult because particularly given how short many appointments are, it's really difficult to stand up and say, yep, I think all GP diagnoses are 100% accurate and correct. I think it's a difficult thing. And if you were going to do a very thorough psychiatric review, maybe you could be a little bit more refined about it. But in the real world, that's not what happens for many patients.
Would you, for this, in the context of this conversation, does it go from descriptive words coming from a doctor's mouth like depressive, anxious, anxiety, to being a diagnosis at the point at which it's kind of entered by the GP onto a medical record?
Yes, it does. And it's very interesting what goes onto the record. Sometimes what goes onto the record is low mood. And that's because the GP doesn't yet feel on this first occasion of meeting that there's enough evidence here, or we know enough to say that this person is depressed. And so they are avoiding giving a label. And that does happen quite a lot. I think if you have prescribed antidepressants, for example, then you are sort of saying this person has depression. So I feel slightly uncomfortable when I discover entries which haven't made a diagnosis but have treated. So almost if you're being treated, you should really be diagnosed first.
Yeah.
That's really interesting. Yeah. Do you think that overdiagnosis is an increasing problem?
Really interesting question. And I don't have any statistics on this. And Elspeth probably has more numbers than I do. I think it's certainly a question in physical diagnoses. There's lots of things that there's kind of what one might think of as scope creep. So you used to be diagnosed with diabetes if you have a sugar above X, and now you get diagnosed with pre-diabetes because you have a sugar level above Y, and this kind of and the limits of when is high blood pressure too high, and those things are coming down and down all the time. So certainly in the rest of medicine, there is, I think, an increase in certainly diagnostic range and an increase in diagnoses which it's not entirely clear are helpful to the patient.
Right.
Is this the case with mental health? That's a really interesting question. And I don't even know how you would begin to answer that, if you see what I mean. We've had a lot of campaigning over the last quite a few years now to say to people, it's okay not to be okay. If you're struggling, go and speak to your GP. It's nothing to be ashamed of. You can get some help. Really encouraging people to go and seek help. And then I think the overdiagnosis narrative is going against that and saying, well, these diagnoses aren't worth anything. They're not, you don't need to do that. And it's how do we do, as we said in the article, how do we do the helping without necessarily saddling someone with a label which may not be helpful to them? On the other hand, they might need the label to get the help they need. And that's where we're in position.
And that's like Elspeth said, we're so entrenched in this medical model system to get, like you said, support at work, benefits, further help, talking to friends who don't understand what you're going through, things like that it's so hard to see a way out.
Is there anything you'd like to add to that, Elspeth?
Yes, I think it's a difficult question to answer because because it's quite subjective, right? Who gets to decide what counts as a beneficial diagnosis? And I think lots of diagnoses are quite ambivalent. They have benefits, they give you access to certain kinds of care and resources, and they might cause harms, which I'm sure we'll talk about what those harms might be. And so who is it that gets to weigh up how those harms and benefits kind of counteract each other? And is that a decision made by individual patients and or clinicians and or public health professionals? So yeah, I don't have an answer, but it's an interesting question.
I think the other player in this is people who'd like to reduce the benefits bill. So that, yeah, when you're saying who makes that decision, I think they're also on that list of people who would quite like to change the numbers, and reduce the number of people who are getting diagnoses, which therefore then make them eligible for support. Quite a lot of us are saying we'd quite like for people to get some support, even if they didn't have a diagnosis.
Yeah.
I don't think that's happening anytime soon.
And as we know, the system is so poor in terms of how those assessments are done that you could have actually 20 diagnoses and still not be found to be not eligible for support, sadly. But that's not how it's perceived, is it? Could you talk a bit... Well, actually, before I ask this question, I've remembered while we were talking that I was misdiagnosed with borderline personality disorder very long time ago. And just by someone, when you said about it's funny what goes on your record and what doesn't, it was by someone who I'd met once in a kind of crisis, and it stayed on my record for ages. And I had so many psychiatrists and GPs and things since then who all agreed you don't have it. But it still took me about 6 years to get it removed because it was still coming up as an active diagnosis. So, yeah, I just remembered that while we were talking, and going on from that, what kind of risks are there associated with overdiagnosis?
I think it depends a bit what the diagnosis is. And I think I guess if you get the diagnosis wrong, there's a risk you'll get the wrong treatment. There's a risk if you get a diagnosis wrong that it alters your view of yourself and your capabilities and your abilities and your role in the world and how you interact with it. If somebody says you're very depressed, you know, and therefore you don't need to go to work, does that make you think I'm not capable of doing these things? So there definitely is a view of self that might be changed by having a diagnosis. There's also other people's view of you and what you're capable of, and their interpretation of your future presentations, particularly to medical services. If you've got a diagnosis on your screen that you suffer from severe anxiety, that will probably affect the way doctors in future might interact with you or might think about your symptoms. And that might be useful, but you could also see it might be not useful if that person then thinks, oh, well, yes, but how they're describing their symptoms is very much affected by the underlying anxiety, whereas it might not be. So you can see that having a diagnosis there on your record, if it's a wrong diagnosis, can be quite damaging both to the patient, both from the patient's own point of view, but also other people's views of them. And changing what's there once it's there can be quite difficult. You have people who say, actually, that just isn't true, but it's not as simple as saying, I don't think that diagnosis is right, please take it off my record. Sometimes that will just happen, but sometimes it's a bit more complicated than that because people want to find out why it was there in the first place.
So yeah, Helen's talked about when the diagnosis is wrong and getting it removed can be difficult. I think there are also questions about when the diagnosis is kind of quote unquote right, you do meet the diagnostic criteria for having an anxiety disorder, for example. But there are still questions perhaps about whether that's useful to you and what that does, whether there's an argument that it may facilitate access to resources and so on, but also could construct you as ill or broken. It pathologizes you. And I think one of the challenges of diagnoses is that they can separate people's distress from the circumstances that cause that distress. Diagnoses, I would argue, are depoliticizing. So what they do is they medicalize people's suffering and they say, you have a disorder, this is an illness to be treated, and it kind of locates what's happening like within that person's individual body. And they might be prescribed medications or offered kind of psychological interventions. But I mean, the example we use in the paper is someone who's feeling worried because they're experiencing financial insecurity, and they see their GP and they're diagnosed with an anxiety disorder. And I suppose what that does is separate their experiences from the circumstances that made them feel worried in the first place. And it offers a depoliticized approach, one that might still be valuable, but means that we kind of make those circumstances invisible, and we offer individual medicalized solutions to what are at least partly political structural problems.
And there's a really interesting point today. I was seeing yet another study of universal basic income, which showed that people who are in receipt of it sleep better, they're more productive, they're less anxious. Who knew that when you're not really, really worried about stuff, that you're about, legitimately worried about things that are really hard in your life, that you stop being so anxious and you sleep better. So I totally get the bit that Elspeth's saying. And what we don't do well within medicine is that separation of totally legitimate anxiety. If I was in your shoes, I would be as worried as you are, from pathological anxiety. And because we don't do that, we don't then, and I think it's because as medics, we don't have any control about the other stuff. So we have some treatments for the pathological anxiety, be that talking therapies or medication, but we have no control over the circumstances of people's life, be that bad relationships or bad finances or whatever it is, that are making people quite understandably anxious or depressed or whatever the condition is.
It's true as well, though, isn't it, that it's always about that balance. So it's about recognising that very often the circumstances will have that political edge to them. Equally, there'll be such situations where there isn't that political edge to somebody's distress. So I don't have a diagnosis for anything, as far as I'm aware anyway. I do take medication, interestingly, which means that maybe there is one hidden away somewhere, or at least I should look at trying to get one. That was a really interesting point you made earlier, Helen. But I think that for me, there's something about one advantage of diagnosis being that it can be a way to better understand the processes that are happening in your head. So I don't have a diagnosis, but I almost certainly have OCD. I've had it for a very, very long time. And I have found finding out about OCD, finding out about that call and response of obsession and compulsion and the risk of getting into that cycle incredibly useful for being able to just label what's happening to me at any given moment. And I think that just having that framework to be able to use is really useful. But then, of course, on the other hand, as you say, there is the risk that for a lot of people, what's happening is that we're just over-medicalising what is fundamentally, as you say, a political issue rather than a pathological issue.
I think this is why I talk about these diagnoses as ambivalent. Both of those things are true at once.
Yeah. And like you said at the start, that your kind of understanding of overdiagnosis as opposed to diagnosis is when it's not helpful for the patient.
Hello, it's Will here, just taking a short break to firstly say hello to any new listeners who may have dropped by, and to ask everyone listening right now, if you are enjoying the conversation and haven't done so already, could you do something for us? Could you pause the episode just for a moment and give us a rating or review in your podcast app? I promise we won't go anywhere. Ellie and I do this show in our spare time, so it really means a lot to get the feedback. Done? Brilliant. And also, make sure you're subscribed so that you don't miss future episodes, which are released once per month. Okay, now back to the show.
Can I jump in here for a second?
Yes.
Which is just also thinking about the durability of diagnoses or the permanence of diagnoses. There's some interesting work that's being done now on ADHD and really trying to maybe reframe how we think about it as less a permanent bad wiring of your brain that means you, well, not bad, but different wiring of your brain that means you work differently from other people, but more as a tendency to kind of struggle with focus in particularly stressful situations or in particular times of your life. So it might be something like depression, where you have times when you need help and need medication, and other times when you don't, rather than it being a constant thing. And I think one of the things that doesn't happen maybe as often as it should in medical notes is that thing of they did have anxiety, but now it's past, or they were depressed, but that's a past problem, it's not a current problem. And this idea that actually people change, and it's not all of the labels that we give and the diagnoses we give are not for life. There is lots of change possible.
Because within that, you learn a lot of, you sort of subconsciously, as you're growing up or as you're going through life, build your own toolkit of how to sort of cope with certain difficulties you have, or I don't know, navigate around certain things you find I remember being diagnosed with dyslexia, but at the age of like 20, when I was in the middle of an English degree, and I was so confused because I was like, well, how? But then when we talked it through, it's like, oh, well, I hadn't had the diagnosis, so I'd like built in, it was my normal, and still is, I guess, but I'd built in all of these ways of sort of working around the things that were difficult. So I also wonder if there's something about overdiagnosis that makes me worry about, people then just drawing a line under it and being like, oh, well, I've got this, so can't do that.
Which is very interesting, because Will was saying that a possible diagnosis of OCD is actually quite helpful, because it then allows you to go and read up about it and find some skills and find toolkits and, work out how you're going to manage this. But the flip side of that, which you were saying, Ellie, was it's I've got this diagnosis, that's me finished, I don't need to think about it anymore, and I can't do these things because I've got this diagnosis. And so, as Elspeth was saying earlier, that there's two sides of each of these issues.
Yeah, they're both potentially true.
And I'm reminded, Ellie, of the conversation we had with Professor Tom Shakespeare, who is a professor of disability studies, who talked about he was talking about disability, but I think he said exactly the same thing about diagnosis, that idea of being given a diagnosis as a label compared to wearing a diagnosis as a badge. Yeah. And I think what's quite interesting is in the disability context, that's regarded as generally quite a positive thing to be given to wear disability as a badge. It's all about disabled identity, and that's generally regarded as a positive thing. Whereas with mental health, I don't know, I think it can be both. I think it could be positive if you're wearing it as a badge and going, right, well, this is a framework that I can use in order to better understand myself and work out how to live a full life. But also wearing it as a badge could actually be necessarily not a great thing if, as you say, it means you're going, well, I've got this diagnosis now, that draws a line under it, and I can't do X, Y, and Z, and that's it. Because it's this kind of fixed mindset, isn't it, that it potentially encourages.
Yeah, and we've talked a lot about how diagnoses can affect your understanding of yourself, but I think it's also important to note the kind of material consequences of diagnoses. So, for example, is it going to impact your ability to get life insurance if you have a certain label on your record? Like, there are kind of structural things that these diagnoses do beyond the individual. And also kind of socially, does it change how people relate to you if they find out you have a certain diagnosis?
Yeah, I also wanted to ask, because it came up in a conversation we were having around the use of antidepressants and their efficacy and things, which isn't not to get into that now. But as part of it, I was saying that one of my fears with the overdiagnosing of mental health is the pharmaceutical consequences of that over the next 10 to 20, 30 years of that person's life. So if they've been sort of maybe overdiagnosed with an anxiety disorder, treated with, but then have sort of after a few years decided maybe they don't work and then move on to stronger where does that, do you worry about the sort of medication outcomes of overdiagnosis as well?
I don't think I worry about people staying on things like SSRIs, because I think they are safe in the long term for the individual. certainly I've known patients try many different medications because none of them have really helped the symptoms that they presented with. I guess there's part of me that is a bit suspicious of the medico-industrial complex, whether that's the vast number of the patients now who are taking medication for ADHD. And it's possible that it's really helping all of them, but it is such a step change. One has to be slightly concerned about it, just as one might be concerned about the sort of long and enduring need for weight loss drugs in people who start taking weight loss drugs. And there's kind of, it goes back again to the political, I'm afraid, which is the solution to our ills always a pill, which is unfortunately always a profit? Or should there be other solutions we're thinking of at a more political or societal level?
Like universal basic income.
It's also worth adding that we like to think of diagnostic categories as kind of objective realities out there in the world, but there's a lot of work exploring how they're fundamentally socially and politically constructed. And there's research that shows how certain pharmaceutical companies have strongly influenced diagnostic categories in both mental and physical health conditions in order to expand the market for their drugs, perhaps. So just to add to Helen's point about the kind of industrial forces, and that's not to say that these drugs can't benefit people or that we're against them, but I think it's important to bring that into this conversation.
How do you think that medical practitioners can have better conversations with patients in such a way that it avoids overdiagnosis?
That's a really interesting question. Some of it is about time, and I think there's been a real move amongst GPs to say, well, I'm going to do fewer appointments per day, but do them properly. I shouldn't be trying to do more than 25 appointments a day because I can't do this work properly if I'm working faster than that. And I think this idea that one should be doing fewer, longer appointments so we actually do have a chance to properly interact, to properly listen. The other thing that goes side by side with that, and unfortunately I think the new direction of the NHS might not be helping with this, is continuity is really important.
Yeah.
Because it's actually really difficult if each time you come to see someone about your mental health, if you have to start all over again. Even if it's written in the record, that's not enough. You want to talk to the person you talked to before. And, if I see people, and I might not have seen them for months, but the last time I saw them, they'd just been bereaved. And then we can pick up the conversation from there. How are they now? And talk about, and I think there's also a way that we should be trying to share those decisions with patients about what they think will be helpful for them, rather than having a knee-jerk response that you're feeling low, therefore you definitely need pills, or you definitely need talking therapies. We should be allowing the possibility that this is bad, but it's not necessarily medical. And I think that we do have an issue with over-medicalisation, which maybe not be quite the same as overdiagnosis, but they have quite a lot of overlap.
I think there's also a role for alternative frameworks, alternative ways of thinking about ill health. There's a book called Drop the Disorder, which I really like, and it makes the case for, instead of asking what is wrong with you, which is what we do when we categorise people as disordered, instead they asked what happened to you. And it's about trying to locate your current experiences in talking about what happened, I'm not sure they use the word trauma, but what experiences have led you to feel this way, rather than this kind of separation that we talked about. And I think frameworks like that might have an important role going forward. Helen alluded to this earlier, but I think it's relevant to talk about the fact that, so I've worked on overdiagnosis for 5 years, and it wasn't until March that the word overdiagnosis had ever really been in the kind of national news. But in March, it was in the news because Wes Streeting, our health secretary, used the term in the context of mental health. And as Helen pointed out, it wasn't a coincidence that was in the context of talking about these cuts to the benefit system, particularly focused on getting sick and disabled people into work and cuts to PIP, which have now been shelved. But yes, I think it's not a coincidence that, having tried to get people to talk about overdiagnosis for many years, finally they did, but only in the context of resource scarcity and cutting support for some of the most vulnerable people in our society.
There's a real irony at play there, isn't there? Because in a sense, it's precisely because of austerity and cuts in support that overdiagnosis is a problem in the first place. Yeah. So there's a real, it's almost a paradox. West Streeting created a paradox, everyone.
Exactly. And so the point we were making in that paper was that in these debates, there's been a conflation between questions about whether medicalising distress is useful and questions about whether people are really distressed. Are they making it up? Are they faking it to get time off work? And it was distressing to watch lots of the conversation take on that tone of kind of talking about sick note culture. And so Helen and I wrote that piece in order to say, people are suffering, that's real, we see that, we acknowledge it. And we have questions about whether medical diagnoses are always the best route or the only route for addressing that suffering. But those are actually separate issues that had become merged together in a really kind of unpleasant way in these debates.
Thank you so much.
Thank you. I think that's a really good point to end on. So thank you both so much.
Yeah, thank you.
Lovely. Thank you for having us. It's been fab.
Lovely to meet you all.
Thanks so much to our guests, Dr Helen Salisbury and Dr Elspeth Dav, for joining us, and you for listening. And please do tune in again next month for another episode of Lively Minds, the Mental Health Podcast.
Please remember that this show does not constitute any kind of medical advice and is not a replacement for seeking professional help. You can find signposting to support on our website, livelymindspod.com.
Make sure you keep up to date with our shows by subscribing wherever you get your podcasts.
Take care and bye for now.
Bye.